Good evening, Dr. Phil here. Today we'll be discussing on intraoperative strategies to prevent postoperative pulmonary complications. Method of anesthesia. Opt for regional anesthesia instead of general anesthesia whenever feasible. Choice of ventilator. The classical bellow-in-bottle design is being replaced by more sophisticated designs such as the turbine and piston pump design. These designs tend to deliver more accurate pressures and volumes. Volume reflector designs deliver gases without moving parts in the respiratory circuit. Ventilation modes. There is no strong evidence favoring the use of either pressure-controlled or volume-controlled or dual-controlled ventilation to improve patients' outcomes. Given the heterogeneity of results of published trials, no specific mode of controlled mechanical ventilation is recommended. The anesthetist should be able to support the patient's respiratory function at any level of anesthesia and ensure that the caveats of the selected ventilation mode is appropriately dealt with. For example, setting appropriate airway pressure limits and alarms when using volume control to avoid barotrauma and ventilator-induced lung injury, as airway pressure is a dependent variable influenced by the dynamic airway resistance to flow and the respiratory system compliance. An increase of the former or reduction of the latter can increase the airway pressure to potentially dangerous levels. Monitor and deliver appropriate amounts of minute ventilation when using pressure control ventilation, as the tidal volume is the dependent variable and is subject to variations that could lead to hypo or hyperventilation. Monitoring of lung mechanics and oxygenation. In addition to standard monitoring, additional monitoring for mechanically ventilated patients is warranted. As ventilation of the lungs is a dynamic system, all mechanically ventilated patients should receive monitoring for lung compliance, driving pressure, and P plateau. Lung compliance. Compliance is defined as the change in lung volume per unit change in pressure, with units mil per cm H2O or liter per kPa. Components of compliance includes compliance of the lung, C lung, and compliance of the chest wall, C chest. The formula is 1 divided by total compliance equals 1 divided by compliance of the chest wall plus 1 divided by the compliance of the lung. C total is normally 75 to 100 mils per cm H2O. C chest is normally 150 to 200 mils per cm H2O. Causes of reduced compliance of the chest wall includes ankylosing spondylitis, kyphoscoliosis, circumferential thoracic burns, etc. Compliance of the lung is normally 150 to 200 mil per cm H2O and is determined by the elastic properties of pulmonary connective tissue and the surface tension at the fluid-air interface within the alveoli. Abnormal compliance impairs the ability to have efficient gas exchange. During reduced compliance, lung expansion becomes difficult, lungs are stiff and non-compliant, volume change is small per unit pressure change. Reduced compliance is associated with increased work of breathing, refractory hypoxemia, changes in FRC, restrictive lung defects, reduced lung volumes, reduced minute ventilation, and posture changes. Age has no influence on compliance. Regarding FRC changes, when there is reduced compliance and increased FRC, this may occur during acute asthma. The tissues are stretched to elastic limit, greater pressures are needed to recruit alveoli. Ventilation at the high FRC has low compliance and high work of breathing. When there is reduced compliance and reduced FRC, for example, obesity reduces FRC and chest wall compliance due to restrictions from excessive adipose tissue. Posture changes. Compliance is maximal in standing position and reduced in supine or head-down position. During reduced compliance, compensation is possible by increasing respiratory rate. During increased compliance, volume change is large per unit pressure change and is associated with incomplete exhalation due to lack of elastic recoil of the lungs, air trapping, reduced CO2 elimination, airflow obstruction, and increased FRC and total lung capacity. This occurs, for example, during emphysema. Static compliance is the compliance of the lung measured when all gas flow has ceased. A pressure volume curve is obtained by applying descending pressures to the lung and measuring the increase in lung volume. The measurement of static compliance is made when there is no gas flow. The formula for static compliance is corrected expired tidal volume divided by plateau pressure minus PEEP. Plateau pressure is the pressure needed to maintain lung inflation in the absence of airflow. In critically ill patients, static compliance is normally 40 to 60 mL per cm H2O. Static compliance reflects the elastic properties, elastic resistance of the lung and chest wall. Causes of reduced static compliance includes ARDS, atelectasis, tension pneumothorax, obesity, retained secretions, pulmonary edema, etc. Dynamic compliance is the compliance of the lung measured during the respiratory cycle when gas flow is still ongoing. The formula for dynamic compliance is corrected expired tidal volume divided by peak inspiratory pressure minus PEEP. Peak inspiratory pressure is the pressure used to deliver the tidal volume by overcoming non-elastic and elastic resistance. In critically ill patients, dynamic compliance is normally 30 to 40 mL per cm H2O. It is lower in intubated patients and depends on the internal diameter of the endotracheal tube. Since airflow is present, airway resistance has an effect on dynamic compliance. Causes of reduced dynamic compliance includes bronchospasm, kinked ET tube, and airway obstruction. Typically, static compliance is larger than dynamic compliance because there is time for volume and pressure equilibration between the lungs and the measuring system. The measured volume tends to increase and the measured pressure tends to decrease, both which act to increase compliance. The gradient of the line at any given point on a pressure volume graph represents the compliance. Specific compliance is compliance divided by the FRC. To correct for the effects of lung volume on compliance, neonates have an equivalent specific compliance as a healthy adult. Driving pressure, the formula is plateau pressure minus PEEP. P plateau. Changes in plateau pressure and peak inspiratory pressure in lung disease. Conditions causing changes in plateau pressure and static compliance causes similar changes in peak inspiratory pressure and dynamic compliance. For example, during atelectasis, there is increased P plateau and peak inspiratory pressure, and thus calculated dynamic and static compliance decreases. Resolution of atelectasis causes reduction in P plateau and peak inspiratory pressure, and thus calculated dynamic and static compliance increases. When there is an increase in airflow resistance, such as during bronchospasm, PIP increases but P plateau is unchanged. When PIP increases, there is a reduction in dynamic compliance. As P plateau is unchanged, static compliance is unchanged. Resolution of bronchospasm results in reduction in PIP and increase in dynamic compliance. Interventions aimed at optimizing respiratory system mechanics, such as alveolar recruitment maneuvers, should be evaluated by measuring lung compliance under a constant tidal volume. SpO2 monitoring helps in detection of hypoxemia, but does not detect hyperoxia. There is inadequate evidence to demonstrate that SpO2 monitoring improves overall patient outcomes and reduces morbidity and mortality. Avoid improving SpO2 by solely increasing FiO2 rather than improving the underlying pulmonary system derangement and VQ mismatch. Induction and preoxygenation. The benefit of preoxygenation with high FiO2 to extend the time for a safe intubation is deemed to outweigh the risk of absorption atelectasis, especially for certain patient populations with high risk of desaturation, such as the morbidly obese. Several strategies can be implemented, especially for the morbidly obese, to reduce the risk of pre-op desaturation by producing a longer non-hypoxic apnea time for laryngoscopy, such as the ramped position. A supine position during induction of anesthesia causes cephalad displacement of abdominal contents, which forces the diaphragm upwards and compressing the dependent lung regions, resulting in reduced FRC, increased atelectasis, reduction in compliance, and increasing driving pressure. The head-up tilt will mitigate this. Another useful strategy is NIV for preoxygenation. However, note that contraindications exist. For example, altered mental status, certain procedures such as face, nose, and esophageal surgery, and emergency procedures. Reduce and avoid airway obstruction, for example, by inserting nasal or oropharyngeal airway. Muscle relaxants. Avoid long-acting muscle relaxants in the very high-risk patient when possible, as residual neuromuscular blockade is associated with postoperative hypoventilation and increased post-op complications. Ensure adequate reversal of neuromuscular blockade prior to extubation. FiO2 should be set to the minimum level to avoid the negative effects of hyperoxia, such as resorption atelectasis, increased oxidative stress, increased reactive oxygen species, results in damage to cellular structures in animal models. Hyperoxia also causes increased peripheral vascular and coronary artery vasoconstriction, reduction in cardiac output, and increase in PPCs. The ideal range is 30 to 40%, as higher FiO2 are associated with worse outcomes. Set FiO2 to 0.4 and below once the airway is secured, and aim to use the lowest possible FiO2 to achieve normoxia, SpO2 of 94% and above. Avoid unnecessarily high FiO2. Administering FiO2 of 0.4 and below reduces the risk of hyperoxia and reduces the masking effect of oxygen therapy and allows early diagnosis of gas exchange impairment. Tidal volume should always be titrated to predicted body weight, as PBW is related to normal lung size. Target tidal volume of 6 to 8 mL per kg predicted body weight reduces post-operative pulmonary complications, and this is recommended. Positive and expiratory pressure. Inadequate PEEP risks reduction in end-expiratory lung volume EELV after anesthesia induction, and this increases atelectasis. Reduced compliance in de-recruited areas and increase in overinflation of aerated areas of the lung results in volume trauma. When there is inadequate PEEP, there is attelect trauma and cyclic lung de-recruitment. Benefits of optimizing intraoperative PEEP. There is increase in EELV, increase in oxygenation, increase in dependent lung ventilation, reduction in atelectasis and attelect trauma, reduction in driving pressure, increased compliance, improved post-op pulmonary function, and reduction in PPCs. An important research done by Deng QW et al. In 2020 titled Intraoperative Ventilation Strategies to Prevent Post-Op Pulmonary Complications, a network meta-analysis of randomized controlled trials. This study employed a network meta-analytical method involving 34 selected studies that fulfilled the inclusion criteria to compare and rank intraoperative ventilation strategies. A literature search was done by two authors independently in PubMed, Cochrane Library, Embase and clinicaltrials.gov, published from inception to October 2019 without applying language restrictions. A network meta-analysis refers to a method comparing more than two interventions, some of which may not have been compared directly head-to-head in the same study. The key assumption underlying any NMA is exchangeability of the studies, i.e., all studies measure the same underlying relative treatment effects, and any observed differences are due to chance. Criteria used for study selection. Inclusion criteria. This network meta-analysis includes study subjects who were surgical patients aged 18 years old and above who underwent mechanical ventilation for general anesthesia, interventions with defined intraoperative ventilation strategies. The randomized controlled trials reported a comparison between a particular low tidal volume ventilation strategy and conventional mechanical ventilation strategy, or between two different low tidal volume ventilation strategies. Studies reporting primary outcome, post-op pulmonary complications, a composite outcome of minor and major pulmonary complications during follow-up as defined in the original studies, with secondary outcomes including atelectasis, pneumonia, ARDS, short-term mortality, in-hospital and 30-day mortality, and other pulmonary complications such as pneumothorax, pleural effusion, pulmonary edema, and pulmonary embolism. Exclusion criteria for this NMA includes studies involving cardiopulmonary bypass or extracorporeal membrane oxygenation, and patients receiving LMA or non-invasive ventilation during general anesthesia. From the 34 selected studies, 5,273 patients were randomly assigned to receive either conventional mechanical ventilation or one of the following low tidal volume ventilation strategies. Key findings. Regarding postoperative pulmonary complications, compared with conventional mechanical ventilation, which is tidal volume more than 8 mL per kg predicted body weight, employing little or no PEEP of less than 5 cmH2O without recruitment maneuvers, the risk of PPCs are reduced by low tidal volume plus high PEEP plus recruitment maneuvers, or low tidal volume plus moderate PEEP 5 to 8 cmH2O plus recruitment maneuvers, or low tidal volume plus moderate PEEP 5 to 8 cmH2O without recruitment maneuvers. Only low tidal volume ventilation plus PEEP of more than 4 cmH2O was associated with a reduced risk of pulmonary complications. Yang CC et al. Reported similar findings. PEEP of more than 4 cmH2O reduces pulmonary atelectasis and improves oxygenation and lung compliance. The lower limit of optimal level of PEEP was found to be 5 cmH2O. However, the upper limit of optimal PEEP is unknown. A study by Bluth T et al. Found no additional benefit in patients who received low tidal volume ventilation with PEEP of 12 cmH2O versus PEEP of less than 4 cmH2O. Excessive PEEP can induce repetitive lung overdistension and release of inflammatory cytokines, resulting in lung injury. Regarding atelectasis, compared with conventional mechanical ventilation, the risk of atelectasis is reduced by low tidal volume plus moderate PEEP plus recruitment maneuvers, or low tidal volume plus high PEEP 9 or more cmH2O and above plus recruitment maneuvers. A study by Levin MA in 2014 showed that low tidal volume with minimal PEEP increases the risk of 30-day mortality. This suggests that intraoperative permissive atelectasis induced by low PEEP can be harmful for the surgical population. Regarding pneumonia, compared with conventional mechanical ventilation, the risk of pneumonia is reduced by low tidal volume plus moderate PEEP 5 to 8 cmH2O. High tidal volume has multiple dangers. It can cause volume trauma, damage to alveolar, vascular, endothelial and epithelial cells, and extracellular matrix, resulting in inflammation and translocation of bacteria. There were no differences in risk among low tidal volume ventilation strategies and conventional mechanical ventilation, or between two particular low tidal volume ventilation strategies after network meta-analysis for ARDS, short-term mortality, or other pulmonary complications. Limitations of this study. PPC were defined as a composite outcome of minor and major pulmonary complications. A considerable variation in definitions amongst the included studies existed. Only a few included RCTs reported post-op ventilation strategies, and this data were insufficient to perform a proper analysis. Lung recruitment maneuvers and strategies were not uniform among the included studies. Individualized mechanical ventilation settings may improve the mechanics of breathing, respiratory function, and reduces PPCs. A tidal volume of 6 to 8 mL per kg predicted body weight and PEEP of 5 cmH2O should be set initially. 0 PEEP is not recommended. Thereafter, PEEP should be individualized. Appropriate PEEP and recruitment maneuvers may improve intraoperative respiratory function and prevent PPCs. Appropriate PEEP is evidenced by the lowest driving pressure that achieves the desired tidal volume and maintains functional residual capacity without causing gross overdistension. Ventilation settings that avoid de-recruitment without causing overdistension of alveoli may reduce PPCs by improving perioperative oxygenation, improve respiratory mechanics, reducing oxidative stress, inflammation, and lung injury. Ventilation parameters should be adapted to specific surgical settings such as laparoscopy, obese patients, cardiac surgery, and one lung ventilation as well. For further details, kindly refer to the article written by Bal L. et al. Intraoperative Mechanical Ventilation State of the Art, 2017. Driving pressure. Driving pressure equals P plateau minus P. A study by Neto AS in 2016, which is a multivariate analysis on data from 17 RCTs, including 2,250 patients, suggested that increasing driving pressure was associated with the development of post-op pulmonary complications. No association was detected for tidal volume and post-op pulmonary complications. Driving pressure should thus be kept as low as possible without causing inadequate ventilation. Lower intraoperative driving pressure is associated with reduced PPCs. Increased driving pressure for a given tidal volume reflects a reduced respiratory system compliance. Modifiable factors that contribute to reduced lung compliance should be rectified. Interventions should restore physiological lung volume while avoiding over or under distension of alveoli. Respiratory rate. The influence of respiratory rate on post-op pulmonary complications has not been investigated systematically. RR is typically titrated to achieve EtCO2 of 35 to 45 mmHg. Theoretical models demonstrated that in terms of energy load and mechanical power, tidal volume contributes more to ventilator-induced lung injury than respiratory rate. Inspiratory-expiratory ratio. Prolonged IE ratio has several effects, such as attenuation of lung damage, increase in mean airway pressure, reduce peak airway pressure, improved compliance, increase in PaO2, reduced alveolar arterial gradient, and reduction in inflammatory markers. There is a lack of evidence of a clear benefit of a specific IE ratio, thus no specific IE ratio is recommended. IE ratio should be individualized by monitoring parameters such as oxygenation, compliance, and driving pressure. Alveolar recruitment maneuvers, ARMs. ARMs are commonly used to treat intraoperative atelectasis. Regarding atelectasis, causes can be classified as obstructive and non-obstructive. Examples of causes of large airway obstruction includes tumors such as bronchial or metastatic, inflammatory cause such as TB or sarcoidosis, or other causes such as foreign body or malpositioned tracheal tube. Causes of small airway obstruction includes mucus plugs, inflammation, bronchopneumonia, bronchitis, and bronchiectasis. Non-obstructive causes can be classified as compressive, passive, adhesive, and cicatrizing. Compressive causes includes peripheral tumor, interstitial disease such as sarcoidosis and lymphoma, air trapping in adjacent lung such as emphysematous bullae, bibasal collapse under anesthesia, and abdominal surgery. Passive, also known as relaxation atelectasis due to loss of contact between parietal and visceral pleura, can be caused by thoracic surgery, pneumothorax, pleural effusions, and diaphragmatic hernia. Adhesive causes are due to lack or inactivation of surfactant, such as during acute lung injury, smoke inhalation, and cardiopulmonary bypass. Cicatrizing causes is due to scar tissue formation, such as in granulomatous disease and necrotizing pneumonia. Atelectasis related to general anesthesia. Atelectasis occurs in 90% of all patients undergoing general anesthesia and can persist for weeks after the operation. Typical mechanisms include compression atelectasis and absorption atelectasis. Compression atelectasis can be caused by dyskinesia, which is impairment of voluntary movement. During the supine position, abdominal contents push the diaphragm cephalad. This causes lung compression and reduction in FRC. Restriction in the movement of a patient's dependent diaphragm results in reduced lung compliance. Reduced movement of the dependent portions of the lung results in reduced FRC. Compression atelectasis can be caused by ablation of sigh breaths. In the normal awake adult, they sigh on average 9 to 10 times per hour. The sigh breath is a normal homeostatic reflex that increases inspiration, maintains pulmonary compliance, reduces alveolar arterial oxygen difference, increases release of new surfactant, and increase the distribution of surfactant evenly on alveolar surfaces and distal airways. Pulmonary surfactant reduces surface tension preferentially in smaller alveoli and reduces alveolar collapse. Compression atelectasis is further accentuated by muscle paralysis, surgical manipulation during thoraco-abdominal procedures, obesity, laparoscopic procedures, the head-down position, lateral position, or one-lung anesthesia. Absorption atelectasis occurs when the flux of oxygen from alveolar gas into capillary blood exceeds waste gas returning to the alveoli as oxygen diffuses faster than nitrogen. Absorption atelectasis may be due to high FiO2. When the FiO2 is 100%, for example during induction of anesthesia, oxygenated gas leaves the alveoli for the blood faster than waste gas returning to the alveoli. This causes alveoli to shrink, collapse, and increases atelectasis. Absorption atelectasis may also be caused by airway occlusion, such as due to malpositioned tracheal tube, mucus plugging of small or large airways, accidental bronchial intubation, or one-lung ventilation. Atelectasis may be rectified by measures such as lung recruitment, avoiding high FiO2, and ensuring airway patency. Effects of atelectasis includes reduction in FRC, increased heterogeneity of lung expansion with resultant cyclic lung overstress, reduced compliance resulting in increased driving pressure and work of breathing, reduction in systemic oxygenation, increase in pulmonary vascular resistance causing right ventricular dysfunction. Alveolar recruitment maneuvers has multiple benefits. It increases compliance and reduces driving pressure. It improves PaO2 and reduces PPCs. Alveolar recruitment maneuvers are efficacious as rescue interventions to revert intraoperative desaturation due to alveolar collapse. Strategies. ARMs can be classified as manual ARMs and ventilator-driven ARMs. Manual ARMs, also known as manual back squeezing technique. An example of this maneuver, the ventilator is switched to manual mode, the reservoir bag is squeezed, and the adjustable pressure limiting valve set to the desired inflation pressure of 30 to 40 cm H2O in non-obese and 40 to 50 cm H2O in the obese to produce sustained lung inflation. The shortest effective time should be used when ARMs are performed. 7 to 8 seconds is an adequate inspiratory time in patients with healthy lungs. Examples of ventilator-driven ARMs. The vital capacity ARM resembles manual ARM. Tidal volume is delivered through the ventilator circuit. The ventilator should be capable of providing CPAP or an inspiratory hold. The PIP level required is 40 cmH2O in healthy patients with BMI of less than 35 and 50 cmH2O for patients with a BMI of more than 35 kg per meter square. Multiple successive ARMs may be required for obese patients. A 7 to 8 second duration of inspiratory hold is adequate in patients with healthy lungs. Pressure-controlled ARM. This involves stepwise increase in PEEP to reach the opening peak inspiratory pressure based on the patient's BMI, as discussed previously. The PIP should be maintained for 10 breaths. Avoid using peak inspiratory pressure exceeding 50 cmH2O. For example, incrementally increase PEEP from 4 to 10 cmH2O for 3 breaths, 15 cmH2O for 3 breaths, then 20 cmH2O for 10 breaths. After alveolar recruitment maneuver, set the PEEP to 12 cmH2O. The target peak inspiratory pressure is 30 to 40 cmH2O in non-obese and 40 to 50 cmH2O in the obese. Volume-controlled ARM is another ventilator-driven ARM. Start with a tidal volume of 6 to 8 mL per kg predicted body weight and IE ratio of 1 to 1. Tidal volume is increased by 4 mL per kg every 3 to 6 breaths until P plateau of 30 to 40 cmH2O is reached. An additional 3 to 6 breaths at this level is delivered and tidal volume settings can be reduced. No evidence support the choice of either one strategy. Caveats. Some authors recommend ventilator-driven ARMs over manual ARMs, as switching back to the ventilator circuit after a manual ARM may result in the loss of PEEP and lung de-recruitment. Manual ARM delivers unstable pressure levels as well. PEEP adjustment after an ARM may be required to maintain alveolar recruitment. Although ARMs are generally considered safe and effective, high-quality supportive evidence is lacking to recommend a routine ARM for all patients after tracheal intubation. ARM may be considered according to an individual risk to benefit assessment. ARMs can cause transient hypotension and hypoxemia, especially in susceptible patients, such as those with hypovolemia, severe emphysema, and COPD. Continuous hemodynamic and SpO2 monitoring prior and during ARM should be present, and ARM should not be performed if contraindicated. One should evaluate the effectiveness of ARMs by monitoring improvements in compliance, oxygenation, and driving pressure. One should repeat ARMs with a longer inspiratory hold or higher pressure if previous ARM is deemed ineffective. Use the lowest FiO2 during ARMs to reduce resorption atelectasis and sustain recruited alveoli, as normal alveoli filled with 100% oxygen tends to collapse even after an ARM. Using the lowest FiO2 helps identify the patient's opening and closing pressures. ARMs should be performed after circuit disconnection or when the ventilator is switched to the manual mode. This is because atelectasis occurs due to loss of PEEP. FRC must be re-established by alveolar recruitment maneuvers to improve lung compliance and to avoid lung over-distension and reduce driving pressure. PEEP versus ARMs. FRC is maintained but not restored by PEEP. Loss of FRC from atelectasis should be restored by alveolar recruitment maneuvers before increasing PEEP. ARMs should be followed by setting appropriate PEEP levels to prevent de-recruitment. Appropriate PEEP should be individualized. Appropriate PEEP is evidenced by the lowest driving pressure that achieves the desired tidal volume, the lowest effective P plateau, and the shortest effective time or fewest number of breaths should be used when alveolar recruitment maneuvers are performed. These are my references. Thank you.